Good afternoon, everyone, and welcome to today's important announcement. It is an honor to provide an update on the significant progress of the Diagnostic and Surgical Recovery Task Force to Manitobans as the Minister of Health. Today I'm joined by Dr. Peter McDonald, the Chair of the Steering Committee that guides the task force, as well as its surgical lead, Dr. Ed Bushell, and Dr. Mary Jane Seeger, Provincial Specialty Lead for Women's Health. In addition, on our screen is Matthew Lister, Project Team Director for the Task Force, and Ian Shaw, Provincial Health System Transformation Lead. And again, they're joining us virtually, and they will be available at the end of the formal portion of today's announcement to answer any questions. Thank you again for joining us. It's been about a month since we launched the task force back in December, and at that time it was clear we needed to take decisive and immediate steps to address wait lists and backlogs that affect the care, health, and recovery of thousands of Manitobans. The task force and its steering committee, guided by local experts with close connections to our healthcare leaders, was created to make the improvements to our healthcare system that Manitobans need. While waiting for surgery, diagnostics, or another procedure, these people and their families are waiting for answers, for relief from pain, for a return to their lives and doing the activities they love and enjoy. That is why today I'm so pleased to share 4 targeted initiatives to increase the number of procedures and improve timely care and quality of life for many Manitobans. First is an agreement with Maple Surgical Centre and several other local partners to improve women's health. Approximately 3,000 women are currently waiting for gynecological procedures, and most of these are day surgeries. Dr. Seeger will go into this in more detail shortly, but we know this is incredibly important to support women's health and women's health recovery. Second, we're shifting how we screen for colon cancer to a diagnostic process called fecal immunochemical testing, or we refer to it as FIT. And it's screening that provides better outcomes for patients sooner. There is another benefit to this change for our operating room capacity. Unlike the previous screening methods, FIT screening does not require an endoscopy. As a result, FIT screening will not only allow for faster diagnostic screening for colon cancer, it will also free up more operating room space for other procedures. As the doctors and other experts leading the task force have told us, expanded capacity to address the backlog depends on many factors. Having the right space at the right time, the right technology, and the right mix of staffing. That brings me to our third announcement. Our government will train and hire up to 13 new anesthesia clinical assistants over the next 3 years. They will be placed in operating rooms across the province, and this will significantly increase capacity while supporting care for patients. We are focused on building capacity close to home, and I've said that many times in my press conferences, and we want to do this as quickly as possible. But we need to look beyond our borders as well to find faster solutions to people who are living in pain. That is why we're working on an agreement with a respected centre in Fargo for specialty spine services as part of Manitoba's out-of-province medical referrals program when the situation is safe and Sanford is in position to deliver the services effectively and safely. While there are no surgeries scheduled at this time, the discussions have created a good framework for joint decision-making that includes managing risk of COVID-19 on operations at Sanford and within Manitoba's healthcare system. Referrals to Sanford Health Fargo will be ongoing and accepted as their capacity allows and is safe for both the patient and Sanford Health. I stress that this is an interim measure while Manitoba builds its own capacity and a new option for patients who are willing to travel and have the costs of their care still covered by this province. Taken together, These are important first steps, and I want to commend the entire task force, the steering committee, and our partners for what they've accomplished thus far. With that, I will call on Dr. McDonald to speak as the chair of the steering committee.
Thank you, Mr. Gordon. Good afternoon, everybody. Since the formal start of the steering committee in early December, we've been working extremely hard, 7 days a week, and left no stone unturned as to how to deal with the backlog of patients who are suffering in Manitoba in the midst of the most intense wave of COVID-19 yet. We've had extensive consultations with over 30 leaders and senior stakeholders in our healthcare system, and have had countless meetings to discuss the many proposals that have been submitted. Some of the problems faced by our system are complex and difficult to solve in the short term, but as promised in our initial mandate, we will address the low-hanging fruit that could be implemented to help Manitoba patients who need care. As the Minister announced, I'll reiterate, number one is a program to service patients who are in the backlog for surgery for gynecological and women's surgery at the Maple Centre in Winnipeg. Almost 3,000 cases are waiting, some since 2019. About 2/3 of those are eligible for day surgery, and we feel up to 1,000 can be accommodated through this initiative. Number two, as the Minister announced, the fecal immunochemical testing, or FIT testing, for the early detection and treatment of bowel cancers. This is a minimally invasive, highly accurate test, much more accurate and specific than the occult fecal blood test. This will lessen the backlog for endoscopy, specifically colonoscopy, by up to 10 to 15%. Further initiatives are being examined in this area of endoscopy and will be announced in the future. Number three, patients with painful spinal conditions on the wait list for spine surgery will now have the option, in certain circumstances by referral to their specialist, to have their surgery arranged and supported out of province by Sanford Health System in North Dakota. More on that by Dr. Bouchel in a moment. Number four, the Anesthesia Clinical Assistant Program. This has been a successful program in the past. Anesthesia services are fundamental to safe and effective surgical procedures. The availability of anesthesia clinical assistants allow anesthesiologists to increase their efficiency by having a physician extender, and they can simultaneously observe more than one patient. The program was successful in the past, as I mentioned, and now is supported to be restarted so that the program and anesthesia services is not a rate-limiting factor in addressing the backlog in the future. We're very excited about these initial announcements, but we recognize that this is just the tip of the iceberg. There's an enormous amount of work to do, and we'll keep updating the public in regular intervals in the future. Thank you very much, and I'll turn it over back to the Minister.
Thank you, Dr. McDonald, for those comments. The targeted initiatives that we're announcing today will significantly increase capacity and reduce wait times. Though the Diagnostic and Surgical Recovery Task Force was announced this past December, work to address the backlog began well before that. So last October, I've mentioned previously, we completed our 5th request for supply arrangement. To date, $13.7 million has already been spent and allocated, with 8,300 procedures contracted, $8.1 million for the first 4 RFSAs, $5.6 million in service delivery organizations on priority procedures such as hips, knees, and cataracts. And let me assure you, there is much more work to come. The task force is continuing to find solutions that build capacity and provide the timely care to Manitobans. You can expect to hear more from us in the weeks ahead. Before we wrap up today's announcement, I want to speak directly to Manitobans who I know are waiting for their procedure, whose lives may be in limbo or who may be in pain. You have every right to be frustrated and skeptical, because we all know that COVID has put extreme challenges on our healthcare system. And those challenges have made these backlogs even worse. But I want you to know that supporting you is at the heart of all of this work and all that we do. That in every conversation I have with the members of the task force and the steering committee, it always comes back to you. Your experience, the timeliness of your care, how quickly we can deal with this backlog now and to build a better system for you in the future. There is hope, and we will deliver on this commitment to you. And now I will pass it over to Dr. Bouchel.
Good afternoon. So I have the pleasure of expanding upon our transfer or delivery of spinal care with a partner in the United States called Sanford Health. This is a huge opportunity for us to increase our capacity to deliver care to our spinal patients who have been seen by our surgeons, diagnosed with a problem that needs surgery, defined what their surgery is, and now in collaboration with the surgeons in Sanford, deliver that care in Sanford when they're able to deliver that care. The process is ongoing right now. The start date is still to be determined, but the care for people on their wait lists needs to happen now while we are developing increased capacity in our system to treat spinal patients and other patients in our province. So this opportunity that we have developed over several months in a controlled fashion with our surgeons and with the surgeons and care providers in Sanford is an opportunity for patients to get the care they need in a much more timely fashion than we're able to deliver right now. I want to specify that we haven't defined exact start times, but the care of the patients on our side and on Sanford's side is what's being considered right now in terms of starting time. Thank you.
Thank you, Dr. Bouchel. I'd also like to call to the podium Dr. Sager to just talk a little bit more about the project at the Maples Centre.
Thank you, Minister Gordon. It really is exciting to be able to talk to you about some plans for the women that are on our backlog that have been created by our ongoing pandemic. As you've heard, we have about 3,000 women on this backlog, representing probably over 5,000 hours in operating rooms. 2/3 of them, so about 2,000, would be eligible to have these surgeries done in a day surgical procedure. Gynecology and gynecologists have been doing day surgery for many, many years and have led the way in developing techniques for laparoscopic surgery. Not all of these women will be able to go to the Maple Surgical Center or to an outpatient surgical center, a freestanding center. Some of them will be required to have their procedures in an environment within a hospital. But for those that will be able to, we're looking at probably 1,000 patients, women, being able to be treated over the next few months at the Western Surgical Center on their off hours, being the weekends. Thank you. Thank you.
Thank you, Dr. Sager, and all the physicians for joining us today, and we are now available to take your questions.
Questions in the room, and then we'll go to the phone. Questions in the room first.
Hi, good afternoon. So for the Sanford agreement, can you talk about the cost to the province, the number of patients that you hope to have treated there, and what it will cost per patient roughly?
So at this time, discussions are still ongoing, and all the costs associated with the initiatives that I shared today is all being handled within the budget that was announced in Budget 2021 for the task force, and that was $50 million. So all of this work is being covered financially under that budget allocation.
And the number of patients that might be eligible for this care arrangement?
So we are in discussions with Sanford. No final amount has been decided upon. As Dr. Buchel mentioned, we want to ensure the safety of our patients as well as the patients at Sanford and in the community that they serve. We're all going through Omicron right now at different stages, and we want to ensure that both our province as well as the locations that Sanford serves is able to handle the needs of their both respective communities.
But do we have an idea of the number of eligible Manitobans who could take this option?
Do you want to take that?
Yeah, so these are patients who are already on a wait list, so they've seen their physicians, they've been referred to spine surgeons, they've been evaluated by the spine surgeons, and we have them on a wait list for a defined surgery. It's not our most complex cases, it's not our outpatient cases that we still have capacity to do. It's this group in the middle, and that tends to be the people we put on wait lists, not our life-threatening and not our very easy, but it's in the center group, and it's a large group. That is, you know, if we talk about thousands of people on wait lists, there might be a few hundred that are appropriate to have been seen, who would be asked if they would be okay with going down, and then be able to be transported safely and undergo safe surgical procedures that we're comfortable with as surgeons here in our province with our patients, referring them down there. So it would be a few hundred, not thousands.
Okay, thank you. And are there any other patients that are being considered for out-of-province treatment, perhaps cardiac or folks who need brain surgery?
So we don't have any plans right now for any other surgical procedures to go down to Sanford right now. Discussions are underway for all types of options for anybody for anybody on a surgical wait list right now. It may include our own resources being used in our province. It may include going to other facilities in the U.S. or in other provinces, but right now we have no definitive plans to move any other surgical cohort down.
Okay. Oh, yeah. Okay, Tom.
Could you tell us what the backlog is now for hip and knee surgeries, cardiac, cataract, and diagnostic testing? And also, will that be published online somewhere so the public can see it and follow it and watch the progress?
Yeah, for hip and knee surgery, we're talking upwards of 6,000 patients. And just keep in mind, we service in a normal period of time that's not pandemic, we can operate on about 5,000 in the province per year. So we're looking at a whole year plus some. And there's another 3,000 in hip and knee surgery who are on a wait list to be seen, who haven't been seen by a surgeon yet. So
In addition to the 6,000.
Sorry,
That's
in addition. So you're looking at 9,000 total if you add those two together. For cataract surgery, we are looking at a wait list of approximately 10,000 and a similar number for endoscopy. And the normal wait list for endoscopy pre-pandemic was in the neighborhood of 1,500, so that's really skyrocketed, and we're very sensitive to that.
Cardiac?
Cardiac, the number is at about 220, and the normal would be 80 to 90 prior to the pandemic.
And is that the sum of all three levels, level 1, level 2, level 3?
Correct, correct, yeah.
And diagnostics, I know it would have to be broken down, I suppose, MRI, CT.
Yeah, diagnostics,
ultrasound.
we're concerned about the MRI wait times, but the CT wait times are not as bad. And the ultrasound wait times are excessive due to the human resources problem of not enough ultrasound techs. So we're sensitive to having, human resources is a common element in a lot of these weight issues. So we're sensitive to that and having to train or come up with alternatives in terms of a human resources plan.
What are MRIs at?
MRIs, I can't give you a number, but the mean wait time, I believe, is about 16 weeks.
And are there targets for all of these numbers that you just gave us?
There are national targets.
No, I mean, do we have targets in Manitoba as to where you want it to be in 60 days, 90 days, or however you're laying out your long-term plans for this?
We haven't laid a timeline on it because we can't predict the pandemic. So there are national targets. We'd like to get back to at least pre-pandemic levels, maybe even better. So.
And will you publish these numbers somewhere that we can see them sort of on an ongoing basis?
There is a website right now where we're looking at updating it and making it more accurate.
That's the Manitoba Health Wait List one, because that's pretty old data.
It
So if you go on there now, you see November.
Correct,
Yeah.
correct, and that's why we're looking at updating it and making it more accurate.
Okay, thank you.
All right, at this time, we're going to go to the phone.
Thank you. A reminder to our reporters on the line, you will have one preliminary and one follow-up question. Up first this afternoon from City TV, Morgan.
Good afternoon, and thank you so much for the time. Oppositions and doctors have called for this to be made a priority for months, long before the backlog got to this point, and they say that healthcare has not been a priority for this government. You know, speaking to Manitobans in pain, in limbo, under stress because of the backlog, why did it take so long for the province to come forward with answers to get this under control?
Thank you for the question, because it gives me an opportunity to remind Manitobans that it was in Budget 2021 that our government committed $50 million to address the Diagnostic and Surgical Recovery Task Force and all the backlogs that you've heard about today from Dr. McDonald. But I want to assure you that we were doing many initiatives before the task force was announced in December. I referenced the request for supply arrangements and our ability to use those arrangements to provide Manitobans with cataract surgeries, hips and knees. And so I just want to assure Manitobans that steps were being taken before the task force was announced to address the backlog.
You know, and one person who is in hospital with COVID-19 right now says that doctors and nurses need more support from government. You know, for people on the front lines who are feeling the strain of the backlog of the pandemic and are feeling that this government has abandoned them in the Omicron wave and are now seeing interim solutions that will take people out of province, not relying on our own system, what would your message be to them, you know, in terms of how much of a priority this is for government if we're not investing in our own system, if we're sending people outside of the province?
So I'll give Dr. Buchel an opportunity after I've commented to make his comments, but I want to say that to all the healthcare providers at all the various levels throughout our system that our government values and appreciates them and the incredible efforts they've been making to provide Manitobans with services during the pandemic, and that we take this very, very seriously. We recognize the burden and that many of you are feeling COVID fatigued, and we recognize some are even saying burnout, and we take it seriously, and that's why we've launched the task force and we're taking these steps. I want to assure Manitobans that we are in no way intended to send anyone out of the province, or shipping is some of the terminology I've heard in the past as well. Individuals will be identified, as Dr. Buchel stated, and they will be meeting with their specialist and their physicians that are currently providing care, and they will have the discussion about whether they choose to go out of the province of Sanford for their care. So this is in no way a forced approach. This is having discussions and reaching solutions that will ensure the person doesn't continue to suffer, that their case or their injury doesn't worsen. And I'll just let Dr. Buchel make some comments as well.
Yeah, the idea that change and the acknowledgement that people are on wait lists and that the wait lists have become worse with COVID only started a month ago with the task force is completely false. This task force is an acknowledgement that we needed more support in our systems that deliver care. But the RFSAs were started before with the support of the government. Developing other means of developing staff, bringing RNs into the system, looking for other healthcare providers in our system, outside of our system, that can help our staff that are working extra hours, evenings and nights. We're supported by our government to do this. Surgery and the healthcare system is not a one switch, turn on, turn off. It's a multifactorial group of people, money, technology, space that has to come together to deliver surgical care. That takes time. It has to be done safely so we don't make wrong decisions that ultimately hurt people. These decisions, once made by the healthcare leaders, are now going to be facilitated by this task force. The healthcare leaders have not asked the government to come up with solutions for how we want to deliver care. The government has come to us and said, come up with pathways to deliver better care in a timely fashion while the pandemic is going on. That's what we're doing. The task force is going to help us facilitate that. The government has acknowledged that we need more help. The normal way of getting approvals, the normal way of vetting things needs to be augmented. And that's what this is. It's not going to magically create solutions. We are going to deal with the pandemic and we're going to build resources simultaneously. That takes time. It has to be done carefully. We're dealing with patients' lives.
Thank you.
From Global News, Brittany.
Hi, good afternoon. My question is for Dr. Bushell. How soon could we start seeing patients heading down to Fargo, and how long would they likely have to stay down there for their care?
So the first question I think has been answered. That is a variable number. We don't know operational situations in Fargo. They, as the minister has stated, are obviously dealing with their own Omicron surge right now. So they have staffing issues, they have patient care issues, they have responsibilities to their communities, as we do. So the first question is, we don't know right now. The second question is, on average, spine patients will stay a number of days in hospital and then determine what type of rehab and follow-up they need after that. If you remember back to what I was talking about, the patient population that would be chosen, it wouldn't be our patients that have life-threatening needs for surgery immediately. Those are complex patients. They stay weeks, possibly months in the hospital, and it wouldn't be our easiest patients who are done as an outpatient. They would be patients that would likely stay a few days to a week in the hospital and then be ready to undergo rehab and be transferred back to Manitoba, where their surgeons who saw them before surgery decided with them what their care plan would be, will continue to follow them afterwards.
Thank you. And I'm just wondering if Dr. McDonald can maybe expand a bit more on the diagnostics. And you said you were quite concerned about the MRI wait times and also the ultrasound. What is the best way that we're going to be able to address that? Is that really a matter of having to wait until we have more people trained, or is there another way we can start hitting those targets earlier?
Well, it's very similar to surgery in that you need space and infrastructure, but you also need human resources. With the MRI problem, it's more of a space and infrastructure. So we need more MRIs in the province. Dr. Essig, who's the provincial lead, has come to us saying that. So the plans are underway to expand capacity on a temporary basis and B, on a permanent basis. So yeah, we need to expand the number of MRIs in this province. Does that answer your question?
Yes, thank you. I'm just wondering if kind of how many we have now and what we would be looking to expand to.
Well, we have several in Winnipeg and then several in the rural areas. The wait lists are longer in the urban area in Winnipeg than they are in the rural areas. So Dr. Essig recommends, and we're still considering this, there's nothing approved, there's no definite plans yet, but his recommendation is more scanners, more MRI scanners within the city limits.
From the Brandon Sun, Karen.
Good afternoon, everyone. I know this has been answered in a way, but just getting back to investing more in our own province. This is something that's been going on for several years, and the pandemic has just exemplified how stripped back the medical system. So going forward, are you thinking about any kind of long-term plans like post-pandemic on how to shore up the healthcare system?
Thank you for the question. So many discussions is underway, and I just want to share some of the initiatives, such as our internationally educated nursing program. About 1,300 individuals have applied for licensure to become nurses here in our province. So our government has committed dollars to ensuring that those individuals can get their licenses. And we're going to continue to work with the College of Registered Nurses of Manitoba, the College of Licensed Practical Nurses of Manitoba, and other stakeholders to ensure we get those individuals licensed and in our system as quickly as possible. And we're going to continue to work with Shared Health and the physicians that are here that are working with us so closely on the backlog to identify what needs to be done long-term in terms of staffing. We're looking at many innovations across the country that are in place in other jurisdictions around different staffing mixes. I think Dr. Bushell might elaborate a little bit on that, but looking across the entire system as to what we can do to ensure that we have the right supports right here in Manitoba to provide Manitobans with the care that they need.
So surgery and the task force definitely have a plan to move forward more than just today or tomorrow. It's weeks and months in the planning. Again, I'll go through this, that surgery needs space, infrastructure. Surgery needs staff. Surgery needs surgeons and anesthetists, and surgery needs systems. The minister just elaborated on some of our initiatives to move our staffing crisis forward. So not only RNs, but LPNs are going to be considered and are being hired into our system now, into the acute care hospitals, to augment the resources in terms of HR. We're looking at different staffing models, but in terms of space, undergoing right now and have been undergoing discussions are where we augment our space or our operating room, recovery room, and perioperative care facilities in our province. Surgeons are being recruited. You just heard about the ACA program. None of these take a day, a week, a month to develop, but they're being announced now because we have thought about them and there are more to come. The last thing is our systems. As has been approved by our government already, and has been asked by different reporters, where are your accurate numbers? Where are the numbers of the people on the wait list? How do we balance the people on the wait list with our resources that we have? We need a surgical wait list information management system, or an ability to track the resources we have with the care we need to deliver. That has been approved. It is moving forward. It has gone through the RFP process. It is now going through its evaluation phase with our care providers and the people who deal with those information systems. We will hopefully have a decision on that system within a few months, and implementation hopefully by spring or early summer. That's a significant portion of our plan to move forward and make sure nobody falls through the cracks. So we are looking at staff, space, surgeons and anesthetists, and our systems, and we're doing them simultaneously while we take care of people who are on the wait list in the best way we know how.
Okay, thank you for that. And just maybe getting back to the spinal surgery, you've already said about 300, and making sure that so far it's only 3. Have been any further discussions about perhaps more heading down to Sanford in the coming months?
I'm going to turn it over to Ian Shaw and give him an opportunity to comment on discussions that are being held with Sanford. Ian.
Thanks, Minister. Thanks for the question. As Dr. Bushell said, the patients that have been identified or potentials in Manitoba that may qualify to do this work. We have been working with Sanford in the context of what's called the Manitoba Out-of-Province Medical Referral Program. This is a process that's been in place for over 40 years and has been used to manage patients in other jurisdictions across Canada and in the US. When patients are identified for those services by their referring specialist, Manitoba has typically negotiated those relationships on a individual basis. In this case, earlier in the year, this was identified as an opportunity by surgeons to work through a relationship with Sanford, and we've been working with them to develop a structure and a process to manage patients, coordinate their care, and have their pre and post care delivered. This process is flexible and it allows for us to manage the patients together. We're in the final stages of that as we take steps with Sanford to identify patients with the referring specialists and care providers on the other side. There will be updates provided going forward.
Thank you.
From CJOB, Rosanna.
Hi there. How close are you to creating and implementing a centralized information management system?
Might want to answer it again.
Yeah, I'm sorry if I wasn't clear the last time, but that's what we call our SWIM system, Surgical Waitlist Information Management System. That was deemed as a necessity at the start of the pandemic, even before the pandemic. That has gone through an RFP process. It has been approved to proceed. We have selected vendors. The vendors have been vetted. We are in the final stages of reviewing the applications with the assumption that there will be a vendor chosen for surgical waitlist information management, e-consult, and e-referral. And then with final decisions being made in the next few weeks, with implementation starting and hopefully completed spring to summer of this year.
Great, thank you. Minister Gordon, we've heard a lot about adding extra nurse training seats across the province. Are there any discussions about increasing the number of doctor seats, physiotherapists, occupational therapists?
So, what I want Manitobans to know is that nothing is off the table. So we're having discussions with the task force, we're having discussions with leaders in the health system, and right now we are focused on our nurses, but that doesn't mean we're not looking at other professionals within the system. So at this time, there hasn't been any discussions regarding physicians, but again, nothing is off the table going forward.
From CBC Radio Canada, Julien.
Good afternoon. I was just wondering if you could clarify and specify why the Maple Center was the best choice for the women procedures backlog.
I'll let Dr. Sager comment.
Sorry, don't think I heard all the question, but I will tell you that there will be likely about 1,000 women who will have their cases done from the backlog at the Maple Surgical Center in the next few months. Was there another part of that question? I didn't quite hear it.
Yeah, the question was, why have you chosen the Maple Center as the best choice for that?
Why? We had to look throughout the system to find where there would be capacity to do this kind of work, and that's where it was located at one of the private surgical centers who is well equipped to handle these kind of cases once we've got the rest of the equipment ready.
Thank you. My next question is also about sending people to Fargo. Of course, I understand that we don't have a cost yet, but eventually we will have one. And there's many medical experts who are afraid that this is going to cost way more than just finding an in-house solution here. What do you have to say to them?
I'll turn that question over to Ian Shaw again. Ian?
Thanks for the question. We're still finalizing the process with Sanford. The discussions that we've been having are enabling us to deliver the care close to the cost that we have in Manitoba.
Thank you.
From CTV Winnipeg, Michelle.
Hi, thanks for taking our questions. I'm wondering about what the next lowest hanging fruit would be. Where are your sights set next?
Dr. McDonald.
Thanks for the question. Human resources is a huge area. We want to do something, as Dr. Bichel's already outlined. It was not that we haven't started on that. we're looking at it actively. It's our biggest problem. It has many common threads. It overrides a lot of our waitlist issues. So we really want to concentrate on human resources. We also acknowledge that we have to do more on endoscopy, more than just the FIT testing, and I alluded to the fact that we want to expand the RFSA program if feasible, and we also need to come up with the cardiac surgery issue is a very complicated problem, but we need to look at that in more detail and come up with some solutions for Manitobans waiting for cardiac surgery.
Do you think this is a good start?
I think it's a good start. As I mentioned, we've been working extremely hard. If I had to guess 4 weeks ago at where we'd be now, I wouldn't have guessed that we would have made as much progress as we have. So I think I'm quite pleased with the progress. That doesn't help people who are waiting for surgery. I understand the frustration, the anguish, but there's a lot of layers to peel through. These are very complicated issues with a lot of complicated background and historical issues that we have to, and all the costing and human resources. So there's a lot to work through, and we're just trying our hardest to get through as much as we can.
From CBC Manitoba, Bart.
Hi there. Just on the endoscopies, so 10 to 15% fewer, but there's no plan to phase out endoscopies entirely, right?
No, I mean, we have a massive wait list for endoscopy, and even if we decrease it by 10 to 15%, we still have approximately 8,000 people waiting. So the wait list is different, rural versus urban, but there's no plans to phase out endoscopy. And I might say that with a FIT test, it's very accurate and very specific, but if it comes back positive, then you still have to have an endoscopy. So it doesn't eliminate the endoscopy portion, but it just means that we can deal with that huge number of patients more effectively.
I understand. It's like rapid test versus PCR. Okay. Dr. Bichelle, you had mentioned earlier that patients could go to Sanford as soon as next week or the week after. Today you're saying that's still up in the air. So what's changed here?
The amount of Omicron cases in our state, or in our province and North Dakota. Any healthcare provider that provides a substantial amount of healthcare to a population is responsible for their population. It's very important that we acknowledge that we have a very good working relationship. Ian Shaw has developed a great framework for us to put appropriate patients in the best care we possibly can in as timely way as we possibly can. But we have to make sure that they're able to deliver the care that they need when they're at their peak of their surge. So at this point, because of the variability in the Omicron surge, we are being cognizant of their need to deliver care to their population.
If I maybe too could, I think the process of making this work takes a lot of coordination and planning. And as we said, normally for this process, these services have been developed on sort of a one-off basis. And so what we've been in the process of working through with Sanford since the spring as a process for managing the patients together. We've had physicians at Sanford, as well as our own system, engaged, talking about how that would work, what the process will be, how referrals will be managed, how things like diagnostic images and patient reports are shared. And I think the key point is that it takes work to get those things established in place and processes activated. And that's really what we're talking about, is it will take time for us to get that going and activated. Our plans are not to do this full speed right off the hop. Really, the idea will be to work through this with a number of patients together. Sanford has been a very great partner to identify opportunities for us to do that when they're ready to deliver care, and we'll be working with the referring specialists in Manitoba to identify patients to the program and start to coordinate and plan the schedule for the services out over the short term, but then over the several months that the time frame that Dr. Buchel is talking about for this agreement.
We now return to room 254.
You spoke about recruiting surgeons. I was hoping you could discuss more about what your goals are for adding surgeons, anesthesiologists, other folks to support surgery in the province over the coming weeks, months.
So it becomes a numbers game. If we're going to go 20 to 25% over capacity to catch up on our backlog, you can only ask nurses, doctors, anesthetists to be in so many places at so many times. We acknowledge that. We're starting a targeted recruitment of surgeons, anesthetists. The ACA program, the LPN program are all coming together simultaneously. That targeted plan will be looking at specifically what areas do we have the ability to ramp up quickly on? Who has the largest volume of cases? What is our capacity on that volume of cases? So if you're looking at what we're going to need, the wait list kind of tells you what we're going to need. We have spine patients. We have arthroplasty patients. We have some cataracts. But we also have, our general population of surgical patients that we need more physicians, more nurses, more anesthesiologists to work as a team together. So those are all underway right now. There's an active recruitment because it takes months to recruit surgeons.
Have you set any preliminary targets for adding surgeons into the system?
Yeah, we have targets within each specialty of what the specialty, based on retirements, people who have moved, what we need in service delivery, what we need to maintain our profession in terms of education and teaching, and all those are being defined by each one of the sections. There's a list that's kept internally, supported by each one of the leaders in their section, but we don't have defined numbers exactly.
I was wondering if Matthew Lister might be able to speak about his analysis of our health system and what he sees as some of the main bottlenecks to delivering surgery and diagnostic care outside of pandemic-related constraints.
Thank you. One of our steering committee members put it very well recently when she suggested that the backlog is not necessarily one individual waiting for one procedure. Actually, many small elements, different parts of the system, each with its own weight or each with its own dependency on another part of the system to move something forward. So there's a real lattice work in different parts of the system that contribute to a wait list. So Dr. Donald, Dr. Michelle, Ian, the minister, have referred to the complexity of addressing the wait list so that we can get patients the care that they need as safely and expediently as possible. This is a dilemma that many health systems face, and I think that the issues that have come to light in Manitoba's radar and our own work are similar to those that jurisdictions are all facing. So whether that is a matter of diagnostic accessibility, engaging remote communities, and then more acute capacity and infrastructure, it's a really shared issue. The interesting thing in Manitoba, I'm speaking maybe a little bit freely, but the integrity and strength of clinical service delivery is outstanding. And so the resources that are available to deliver those services, I think are very, very strong. What I have noticed anecdotally as well, every member that we've spoken with has been absolutely committed to a common theme of waitlist reduction, helping do ideas to expedite payment. So we have a very, very strong, committed and informed group that is supportive in moving this event.
Before we go to that question, I would like to add to what Dr. Buchel said about recruitment and staffing, that our government did commit to adding 400 additional nursing seats, and we have made announcements. You followed some of those announcements at University of St. Boniface, and we'll continue to make announcements going forward. But I also wanted to recognize the individuals that have come forward to participate in the critical care nursing program. So we continue to see individuals going through the program. I'm told that 30 individuals have signed up for February. So even while we're looking at other options and other programs, we're continuing to see individuals go through the system through these initiatives that we have already created and are being moved into our medicine and ICU spaces. So I want to recognize them and thank them for coming forward. Your question.
I have a question for Dr. McDonald. To what extent are we seeing cancellations or postponements of surgeries and other hospital procedures now as a result of staff being redeployed to deal with COVID patients in hospitals?
Well, it certainly isn't helping that we're in a very intense pandemic. We're hoping it's short-lived, but yes, there's been some surgery cancellations recently and redeployments mainly to medical wards as opposed to ICU, because of the large number of patients being admitted to medical wards, not as much to ICU because of the nature of Omicron. But it's not helping, but we're not going to sit around and wait for Omicron to go away. We're working hard on planning how to be prepared for the next wave, if there is one, hopefully not, but if there is, and how to be prepared for the future when Omicron subsides and we're able to address the backlog.
And are you able to quantify that in any way? The numbers of surgeries that we're still seeing postponed or delayed or canceled, or other hospital procedures? Do we have any way of quantifying that? And is it the same as a couple of weeks ago? Is it getting better? Or
it's not
getting
the same.
worse?
Yeah, it's not the same as a couple of weeks ago because we're modifying our approach. Right now, as Dr. McDonald said, we're seeing not the same volume of ICU to inpatient beds. So the request from the system of surgery is different. They don't need our recovery room nurses. They don't need to the same degree our operating rooms. What they need is inpatient beds. So we have transitioned from shutting down operating rooms to limiting our inpatient capacity. That means that our outpatient procedures will go into those operating rooms and be done at a higher volume. You might actually see an increased numbers of cases being done. But we have shifted from inpatient cases that require inpatient beds to outpatient procedures as the requests from the system change of surgery. We modify what we do to maximize our ability to continue to deliver care.
And so you're using more surgical beds for medical bed needs?
Yes.
Yeah.
Absolutely.
What about staff absenteeism from COVID illness? Is that having an impact on delays of surgical procedures or postponements of surgical procedures?
Well, it's affecting everybody from your restaurant all the way up to your healthcare. We know that a significant portion of our population will get COVID now, vaccinated or not vaccinated.
But is that impacting the cancellations of surgeries and other hospital procedures?
So the vacancy rates or the sick rate calls right now are not a major determinant in canceling surgeries as much as a shift in the type of surgeries we're doing. So we're experiencing that. We've modified our workforces at the various hospitals to still continue to deliver the surgical care based on the resources that are left. It is putting pressure on our staff. We absolutely have to acknowledge that our staff are working harder because a portion of them are off sick or contact isolation, etc. So we fully acknowledge that the people that are healthy and well are delivering more care with longer hours under stressful conditions to maintain as much capacity in our system as we can.
Thank you.
Thank you very much, everybody.